I request Dr. R.K. Srivastava to please come and hit a century.
अच्छा चेंज करने के लिए क्या है, कैसा करना है इसको? ये नेक्स्ट प्रीवियस ओके। अभी वो स्क्रीन में लगाया क्या हुआ आया? We'll start. Good afternoon to you all, respected chairpersons, my senior colleagues and dear friends. I bring greetings from Ntpc Ramagundam Dhanvantari Hospital. My topic is palliative pain management. We all know pain management, palliative management. What do you understand about that? Before going to that, let's get into some of the quotations. Pain is more terrible lot of mankind than even death itself, said the Nobel laureate Albert Schweitzer in 1931. And pain is, for all happiness man can gain is not in pleasure, but in the rest from pain. Uncontrolled pain remains one of the most greatest problem of the health delivery systems. Sir William Osler said, he knows, one who knows syphilis knows medicine. Syphilis simulates every other disease, but in 21st century, the saying, whosoever knows pain knows medicine. Pain affects every system, and treating pain requires knowledge of pharmacology, medicine, and technical skills. So palliative care, what do you understand by palliative care, or what we are trying to aim at? Palliative care is the care, do you think it's for those who are dying, or end of life care in case of cancer, or it is something else? The palliative care, the definition by IASP, International Association of Study of Pain, is the active total care of the patient with self-limiting disease and their families by multi-professional team when the disease is no longer responsive to curative or life-prolonging treatments. So we extend palliative care in cancer, diabetes, COPD, HIV, renal failure, and chronic pain, or the neuropathic pain. As we know, these diseases can never be cured. So the palliative care, what we look at and what we are going to do is to improve the physical, psychological, social, and spiritual aspects of the patient. Palliative care is a low-tech and high-touch care. So what we are trying to do is to improve the quality of life. What quality of life means to a patient? I'm asking to the house, is it a correct prescription, and can we manage the pain with these two drugs? In this sort of prescription, it can never be. Because the failure in pain relief in palliative care is due to lack of knowledge about the pharmacology, precise drug for the condition, precise doses, timing, and follow-up of the patient. Morphine by mouth is the global strong opioid of choice for the cancer pain, and no other drugs can manage the cancer pain. But if you are having a breakthrough pain, then you can go for these fentanyl-cited patches, lozenges. Fentanyl is available in 25 mics, 50 mics, and 100 mics patches, which works for 72 hours. You have buprenorphine patches, which works for 5 to 6 days. You have capsaicin patches, which works for 28 days. That is not available in India, but it is FDA approved, marketed in US. And if at all the patient is having pain, you can go for injectable fentanyl, which is short-acting or ultra-short-acting. So neuropathic pain in cancer, because I have said it beforehand, it is because of the nerve compression or filtration because of the plexopathy, spinal cord compression. Then treatment induced because of the surgical incision, phantom limb pain, chemotherapy, peripheral neuropathy, and radiation fibrosis or plexopathy. Neuropathic pain in cancer, the adjuvants for the analgesics, you give corticosteroids, antidepressants, antiepileptics, NMDA blockers, antispasmodics, muscle relaxant, and spinal analgesia. So interventions, if you have remembered last Medicon, I was presenting this one for the myofascial pain syndromes. Trigger point, you can feel it, it is a hard nodule, just few millimeters, and 0.5 to 1 ml of lignocaine 1% is more than sufficient to break these trigger points. And you can go through the neck, these are basically myofasciitis, myofascial pain syndromes, you can comfortably fast plot your trigger points and go for the injections. Like the previous speaker was saying about trigeminal neuralgia and all, you can go for the maxillary nerve blocks, mandibular nerve blocks, or continuous block. Ganglion impaired blocks also can be done in case of cancer pains. And celiac plexus blocks for carcinoma of pancreas, stomach, gallbladder, or liver. Most of the people go for the posterior approach, but some of the people, if see a stomach, they go for an anterior approach for the celiac plexus block. This is the posterior approach. You can see the last image, hold, and over here you can see this is the outer. The dye has beautifully sprayed along the outer. This is the outer. So epidural and intrathecal opioids, where you can give 1/10 of the dose of morphine, and if you are going to give spinal, is 1/100th of the dose of morphine is sufficient to manage the pain. And nowadays we are getting this intrathecal pumps. And there are different type of things. You can go for the intrathecal 100% alcohol or alcohol glycerol, but this is basically for the advanced stages of the malignancy. So it's not only the pharmacology or the interventions, there are alternate therapies also, alternate therapies like acupuncture, physiotherapy, physical and electrical methods, hypnosis, relaxation trainings, behavioral therapy, yoga, and medication. But the most important thing is the psychological part of the family as well as the patient. And the earlier you declare the things, it is better for the patient and for the management. So to the take-home message, I can say to this audience, breaking the news at the earliest, treat pain with appropriate pharmacology, dose should be according to the pain scores, interventions as the last resort. So thank you for your patient hearing. Hope this is the only bit that makes honey without flowers. Thank you for your patient hearing.
Thank you, sir. Questions will be after both the sessions. Thank you so much. Sitting from morning, you must be having low back, but we have arranged some epidural steroid for you. And Dr. Sagar will be there to help us. From Tanda, Dr. Sagar, please.
Hello. Hello. Respected Dr. Anita, Dr. Mudit Kulshrestha, and seniors, delegates, a warm welcome on behalf of Ntpc Tanda. As this can very well be visualized, My presentation is role of epidural steroid in backache. I'm sure there is nobody sitting in this gathering who has not experienced the bitterness of backache. It's so common to happen. Today's presentation is dedicated to Sanjeevani Hospital, Shakti Nagar, where I worked for more than 22 years and also conducted few studies there. I salute Sanjeevani Hospital and team for wonderful cooperation and coordination. Even today, low backache is one of the most common cause of physical disability. If you go to magnitude of problem, we can understand these data I collected from Sanjeevani Hospital from 2009 to 2012. Average attendance of patients complaining of backache for per year used to be near about 6,000. And out of these patients, near about 2/3 patients, they used to respond with a conventional treatment. But what about the 20% patients, that's 1/3 patient, the 2,000 patients, they used to come again and again as a common or chronic backache cases. So it's a matter of concern. Concern for the industry is a major cause of absenteeism, loss of work days, and the delay of targets, and of course affecting the productivity. Then being the doctors of Ntpc have responsibility to take care of our employee, so it's a matter of concern for doctors, and of course this affects the referral cost also. Let's see what is the applied anatomy for this backache. Very notorious, this longitudinal ligament, muscles and joints. The components for backache, the intervertebral disc disease, and the etiological factors are simply mechanical injury, weakness of the muscles, herniation, and the enzyme PLA2 and P substrate, reticulopathy. The clinical presentation, there is often the history of weightlifting, reticular pain, radiating and dermatome involvement, there is paresthesia. Pain worsening can very well be noted when there is a flexion or leaning forward. There is, on examination, there is decreased muscle tone. There is positive straight leg raising and reverse positive straight leg raising test. This is the often posture what we observe when a patient of acute backache with intervertebral disc disease come to our OPD. This is the posture. Cannot sit. Recently, a patient came to my OPD with this acute onset of backache. He was straight, stand up. I just offered chair, please sit down. He said, no, I cannot sit down. And this is a real incident. For last 36 hours, हम सर बैठ नहीं पाए हैं, बहुत मुश्किल होती है, आप खड़े खड़े देख लीजिए. So I had no option then to examine him, and in standing position, then somehow I took him on this examination couch. And another component of backache, very important, that is lumbar canal stenosis. The etiological factors, thickening of the joints, ligaments, osteoporosis, disc space reduction, then of course herniation of the disc, Then clinical presentation, this includes pain along the sciatic nerve, neurological. Claudication is very, very important in lumbar canal stenosis. Then another important thing to note is pain worsening when there is extension. So altogether what happens is, this is the posture, but for the comfort, these patients, they adapt. They cannot stand straight away. The conventional treatment, we all know, this includes NSAIDs, opioids, and local heat, cryotherapy, physiotherapy, and rest. Then, what is the advantage? We all know the cost is less, compliance is high, ambulatory patients early, and of course, more than 60% or more, they respond well with the conventional treatment. With then what are the disadvantages? Prolonged treatment, drug-induced complication, as we all know, when these patients are put on. Then what are the other remedies will be left with us? Acupressure, acupuncture, and epidural steroid, and of course, then last but not least is surgery. Then why I have chosen steroid administration in epidural space? This is a very important question to be answered. That the basic idea to place the epidural steroid is that we all know the property of anti-inflammatory property of steroid, but the most precise way to deposit the drug, which is known for its anti-inflammatory effect, is epidural route, where this, in the close vicinity of the tissue involved, can be targeted by anti-inflammatory effect. So this is epidural steroid is chosen. Apart from that, there is a direct inhibition of neurotransmission, and of course, then this enzyme PLA2 and P substrate, they are also blocked, which play a very, very major role in conduction and propagation of pain pathway. Then there is another effect that capillary permeability is also decreased. Then what are the indication? We have already covered that part. Then of course, contraindication for epidural steroid is equally important to understand, and these are any kind of infection, it is local or a systemic infection, bleeding disorder, sensitivity, and acute cord compression, of course, then refusal of the patient, and uncontrolled diabetes mellitus, and patient having congestive cardiac failure and pregnancy. These are the patients to be taken very care for that. So, in a precise way, all patients due for epidural steroid treatment have to be examined, and history has to be taken in the same way as they are evaluated for any kind of surgery, and epidural has to be given. Apart from that, a major concept for the contraindication steroid has to be kept in the mind, and this is another thing. Then examination, I have already mentioned the examination part. Investigation, all general investigation taken care for ruling out bleeding disorder, and of course for anatomical evaluation and evaluation of the pathology in the spine, MRI and CAT scan, whatever required, has to be done. What are the prerequisites? A written consent, epidural set, and monitoring facilities, drugs, of course. And it's very curious to understand where exactly drug has to be deposited. See, we all understand this is skin, this spine, that this is supra. Okay, you can appreciate this green color part. This is ligament flavum, and then there is other membrane that is dura mater. So between ligament flavum and dura mater, this extradural space. You can admire here. This is this orange color. This is appreciated here. This is posterior epidural space, and another one is this anterior epidural space. We deposit here, drug is deposited here in posterior epidural space, or this generally this epidural space or extradural space. These are the various size of syringes from 2 ml to 20 ml. They are all used for this procedure, and you can see the needle. This is 2E needle with different, and usually 16 number of 2E needle is used for this. And this is the drug. This is methylprednisolone here, and this is the 2% xylocaine with adrenaline. As per protocol, methylprednisolone 60 to 80 milligram or 40 to 60 milligram is to be administered in 3 doses as per the requirement. And we have to be cautious to avoid a rapid and a high volume injection, always lumbar region as it is low backache, and no steroid in spinal space to be administered as a rule. The probable complications: hypotension sometime, transient retention of the urine, and as happens in other epidural administration, there can be abscess, hematoma, and some complication may be associated with the steroid, its own effects. This is the statistics for 2009 to 2012, what we taken total number of cases we took in the study was 131. Over the follow-up is 6 months, 85 patients, that makes near about 65% cases, they were symptom free, whereas 38 patients, they partially relieved from the pain, and 8 patients, of course, they could not respond to the pain. The conclusion of the study is epidural steroids are effective, side effects are minimal, patient satisfaction is good, and optimal cost effective is there. Thank you very much, and sorry for the interruption, and thank you for patient hearing.
Thank you, sir. Thank you for the nice presentation. May I request Dr. B.B. Mishra to please come on stage. Thank you, sir. Now a small moment for Dr. Sagar. Thank you, sir. May I request once again, we have Dr. Rai among us, please, sir. Sorry for the exercise.